So we'll be talking about hypertension, but again, we'll be taking a different approach. We won't talk about hypertension as in an outline form or summary or highlight the different parts of a textbook chapter. Pretty much nowadays, the textbook chapter looks like condensed versions or summaries of clinical practice guidelines, and it depends on what country you're in, which guideline it follows. If you're in Europe or in the United States, or if you're in a country where a lot of doctors use the guidelines coming out of one particular country, and that can actually be a problem if you're in a low resource country and you have doctors coming in trained abroad, the so-called experts of your country bringing in the guidelines of a developed country, then there would be some serious concerns, in particular relating to difference in context, resources, and such. Of course, the problem is your own low resource country doesn't have the capability, or maybe it does, but the experts in your country would rather just follow whatever they've read coming out of the developed country instead of coming up with a simpler low resource guideline. We'll go really practical, but we won't cover the entire topic. Nowadays, you can actually Google clinical practice guidelines for hypertension, and what you'll see is a whole bunch of guidelines coming from all over the place. You have conservative guidelines, you have guidelines coming from experts from one country, a country in Asia, from the Europeans, from a subspecialty society, from hypertension specialists in Europe, from hypertension specialists in the United States, from cardiologists, from nephrologists, and all sorts of places. You even have guidelines coming from general practitioners or general medicine doctors or family medicine doctors. Of course, we do know that sometimes those groups, especially if, if you're an internal medicine group and your subspecialty group under your umbrella organization already put up a guideline, of course, you dare not come up with something that looks different from what they came up with, right? So now family med would be a different thing. Family med prides itself in being more grounded and being more realistic in their approaches. So if ever they actually do come up with guidelines in places where they are still gutsy enough to go against the modern medicine tide, which is, the pharmaceutical firms supply the information, the experts from the subspecialty field come up with the guideline, and you, the primary care doctors, follow what they say. Now, if you have a group that's brave enough to stand on their own, then they might come up with a guideline which is somewhat different from the subspecialty group's guideline. And usually it's more conservative because it's more aware of what's doable and realistic and what is not. Of course, the guidelines are also written for all sorts of reasons. Like, for example, the guideline might be written in a sense that, we think this is the most important thing, or this is the ideal way, or this is the best way to do it. And hopefully your country will come up with ways to fund this so that the entire population who needs this treatment in your country would have access to what we recommend. So it's like we come up with a guideline, now advocate for the guideline in your country. So it could be that. Now, it could be that the group making the guideline are aware about what's really possible and what's really impossible, in the next 1 to 2 years. So they would write something that's actually doable and not something that would hopefully be done, even though they don't think it would get done. Now, then suddenly you have a guideline which cannot be applied all over the place and can only be applied in the more resourced communities in your country, in which case we shouldn't be calling it a national guideline to begin with, right? So anyway, the first thing that you'll see different, at least compared to what was being taught when these guidelines started becoming popular during its early years, would be different ways of determining whether someone has hypertension that could be a problem or not. In the old days, you just go to the doctor checks your blood pressure, and that's pretty much it. Now, of course, even during those times, everyone knows that that's not enough. So they will come up with things such as, you have to at least check it 2 or 3 times before you're sure that it really is, because the blood pressure, even during that time, everyone knows that the blood pressure varies all throughout the day, and there's all sorts of reasons why the blood pressure goes up. Now, nowadays, people can easily buy blood pressure monitors, and it's not manual anymore. Even if you're not a nurse or a doctor, you can easily take your blood pressure at home with an electronic device that's decent enough to give you decent numbers. And you also have the fancier, more expensive 24-hour ambulatory blood pressure monitoring. Some groups are actually creating guidelines just for blood pressure measurement. Now, if you look at most of these guidelines, well, we won't go through each and every detail, but the general idea is blood pressure varies all throughout the day. It can be caused by all sorts of reasons. It can be very high when someone goes to the doctor's clinic, a very popular concept even during our time when we were trainees. So they called it white coat hypertension, doctors wearing white coat. Or it could be normal in the clinic, but it can be high at home. So if we just consider that, then you have a situation where it's only high in the clinic and normal all throughout the entire day when the patient's not in the clinic. That's white coat hypertension. Or it could be high at home, but normal every time the patient goes to the clinic. So that's a masked or undetected by the doctor kind of hypertension. Now, the most obvious hypertension is it's high whether or not the patient is in the clinic or at home. It's high in the clinic and at home. So that's the easy one. Now, the ideal case scenario is the blood pressure is good in the clinic and at home. Now, of course, the blood pressure varies all throughout the day. So when we say the blood pressure is good, what we mean is the blood pressure is staying within the suggested systolic and diastolic blood pressure parameters. What can easily be missed would be the fact that it varies all throughout the day, and the reasons why it varies is very complex. Actually, no one has clearly figured out what the factors are and how they interact and how they influence the blood pressure. So you're looking at all sorts of things, like something internal inside the body, internal, intrinsic cardiovascular, regulatory mechanisms or systems, something environmental or outside the body or extrinsic, something behavioral, something that the patient does, the way he sleeps, the stress level, the way he eats, and other things. That's the reason why the blood pressure is varying all throughout the day. Of course, the idea is you can only measure blood pressure depending on what resources you have available. Now, if we're talking about low resource or moderate resource countries, you might not have a 24-hour blood pressure monitoring, or you might have, but it's going to be too expensive for a lot of your patients. So the idea is just try to get the sense of what it looks like. If you don't have any other choice, then you fall back to the usual, well, you just check in the clinic. Now, you can be creative and say, well, is there any clinic or government health center near you? Well, maybe they can check it more frequently, and then you can come up with your blood pressure diary and bring it to me, right? Or you might say, well, the blood pressure machines right now are so cheap, then maybe you can buy a decent one. Now, of course, the question is, what are the decent ones? Now, some countries have come up with lists to advise patients what the decent ones are. Of course, those lists are usually country specific. Not all those machines are available in each and every country. Now, of course, right now we have like international online stores, so that would be easier. Of course, that also allows sellers of non-decent machines to peddle their blood pressure apparatuses. Now, most of the time, the patient actually buys the blood pressure machine without telling you. So my advice is it's very cheap, and a lot of patients actually buy it or would buy it since they're very scared and concerned about blood pressure, partly because of how we present it to them. We sort of exaggerate the entire situation, and so, well, actually they think they'll truly have a heart attack or a stroke if it's beyond the numbers we tell them, which is not true. But anyway, so they buy the BP machine, and then sometimes the BP machine they buy is not too good. So the advice is, right off the bat or earlier on, ask them if they're planning to buy, or advise them if they're planning to buy. If you want to, guide them so that they won't waste their money in something that doesn't work. Now, that requires that you have an idea about what machines are available in the market in your country. Most people are right now buying in online stores, so at least you have some idea, a few affordable, reasonably priced machines available in the market that you can suggest to the patient. And then the next suggestion is, since most of the time you're not really sure, it might even have the reliable brand, but it's not really that brand. It's just, the name put on a non-reliable machine. There's lots of questionable practices such as those are common. We all know that. So you still have to check it. So my advice is you ask them to bring their machine so that you can compare it with the machines in your hospital or your clinic, because especially since you're going to use the numbers that the patient is getting out of that machine to guide your management, right? Now, the suggestion is try your best to make sure that the average blood pressure is within the parameters of the systolic and the diastolic blood pressure you're aiming for. The other suggestion that you might see is, even if they're mostly within the range that you want, you also try to control episodes of BP spikes that happen a few times in the day, because even those spikes can cause problems in the long run. Try to make sure those spikes are not happening very frequently, or at least they are very rare. And if they do happen, so you can almost guess, or what's causing them. Like, for example, the patient started eating chips filled with salt for one entire day. Well, obviously, even if you're swallowing 3 pills, that's going to make your blood pressure spike. So the solution to that is you tell the patient not to do that again, right? The more reasonable solution to that is not to make the patient buy more drugs that he cannot afford, because, again, we're dealing with a low resource community, but to tell the patient not to do that again. That's pretty much the idea. Now, when we talk about the variation in BP and it being caused by all sorts of things, internal and external factors, that indirectly points to the lifestyle problem, because hypertension, diabetes, and a lot of other chronic problems are pretty much related to lifestyle. Lifestyle plays an important role in hypertension, diabetes, and other chronic medical problems. So when the guideline says we're giving you, or you should try lifestyle management for 3 to 6 months, they're referring to a serious attempt at lifestyle management for 3 to 6 months. Now, of course, the entire list is long, but the more common ones would be, reducing the salt intake, maybe at least to less than 5 grams a day, eating more fruits and vegetables, which is, a healthy diet, more vegetables than fruit, actually, exercising, being physically active, the more the better. You can always say, 30 minutes so-and-so times a week, but, the more the better. Every day is better than just a few days per week, obviously. Reducing alcohol consumption, limiting the intake of foods high in cholesterol and fats, and so on and so forth. Lifestyle management is actually a very important thing when you look through the literature or the ideas of the early pioneers of general medicine, generalist practice, and family medicine, because these people are actually the general practitioners of the olden days, like 1940s to 1960s, and they witnessed the medicalization of most of these chronic medical problems, and in their mind, the lifestyle factor or issue is becoming less and less important as far as actual practice is concerned. So you'd see a lot of them writing about it and pushing for a more non-pharmacological lifestyle approach to the management or prevention of all these chronic medical problems, including hypertension. So unfortunately, they weren't too successful, because right now, it's more medicalized than before. Of course, we do know that right now, the way clinics are set up, the way doctors are motivated to try to earn enough to run their clinic and have a decent life, usually you might find yourself seeing patients every 5 to 10 minutes. And you have to do everything in 5 to 10 minutes, do the assessment, talk to the patient, do your physical exam, tell them what you think, decide on the test, decide on the medication, explain to them the important details they have to remember about the medication, about taking the medication, and everything else. Now, in addition to that, you're supposed to do non-pharmacological lifestyle management, right? And you're not just handling one medical problem. You might be dealing with diabetes or a pre-diabetic patient, someone with elevated blood pressure, who will probably end up with a medication if you are not too successful in your lifestyle management. So, but how many minutes did you spend trying to push for the lifestyle changes? Well, very little. probably 1 to 2 minutes, or maybe 4 minutes at the most, and you have 35 more patients waiting in the waiting area, so you cannot spend 10 minutes just making sure that the patient has a good shot at changing their lifestyle and behavior so that they don't end up swallowing a medication for the rest of their lives, right? Of course, that might work for you because nowadays also there's an increasing motivation to prescribe the medication. There's lots of incentive for doctors to prescribe more and more medication. Hopefully you don't think that way, but the more prescription you give, the happier the supplier of the medication is. And the happier the supplier of the medication is, the more sponsors you can get for your fancy conferences in 5-star hotels and for your trips abroad and all sorts of other goodies, right? So again, you don't just say, well, you should limit your salt, don't eat cholesterol, or don't eat a lot of fat, and exercise, and that's pretty much it. And then the patient comes in, you check the blood pressure after a few weeks and still high, and then you say the same blurb again, and then the patient comes back to you not really able to do it. All behavioral therapists and lifestyle counselors will tell you that's the poorest way of implementing lifestyle management. I mean, it's guaranteed to fail, right? And yet you keep on doing it. So what happens is you either give the medication earlier than 6 months because you and the patient are saying, well, doesn't seem to be working. He cannot do it. And I've been at it with this 2 to 4 minute short advice every time he passes by the clinic every few weeks. And it doesn't look like it's going anywhere. Even if we do it for 3 or 4 more months, might as well give this person the medication right now. And the patient would agree with you because, he doesn't know how to do it, or it's hard for him to do, and he might as well take the pill and get it over with, right? Now, of course, the real problem there is you did your lifestyle counseling and lifestyle management poorly. That's the real problem. Now, what you'll also notice in some of the guidelines is this issue about the younger population and how to treat them. Because, everybody knows that hypertension can increase your cardiovascular risk and increase your risk for several complications. But the risk for the older population is different from the risk for the younger population. So for a very long time, nobody knows what to do with the younger population who have a somewhat high blood pressure. In the old days, they just say, well, just keep at it. If it's not really that high, just keep on telling them to do the lifestyle changes. And because they don't have any proof that giving the medication would significantly decrease their already decreased risk. Nowadays, they put a deadline. Like they'll say, well, it's really high and we're not too sure, but probably increases their risk a little bit. Well, at least the hazard ratio is higher. So do the same thing. Try non-pharmacological lifestyle stuff for 3 to 6 months. If it doesn't work, give them the drug. Now, as far as numbers go, as of now, of course, let me tell you, these numbers have been changing every few years. What I tell you right now might not be the numbers a few years from now, or maybe even next year. But as of now, the magic number is 130/80, meaning anything above would require some form of management. Now, it depends. If you're dealing with a very young population and or you calculated the risk, actually it's risk-based. So if they don't have a lot of risk, and you can use a tool that calculates for 10-year risk, and then you go for less than 10%, or you can use some other tool. I mean, that's not the only tool available, but in your mind or your community of doctors agree that it's low risk, then you don't give the drug right away. You start non-pharmacologic behavioral lifestyle management. Now, if you're not successful in 3 to 6 months, now there's a range. I would suggest that if you're really serious about it and you're doing things seriously, then go for 6 months. Now, if you're really not doing anything, just giving a 2 to 3 minute speech about do the DASH diet, don't eat cholesterol, and do the exercise, and just keep on repeating it every 3 to 4 weeks, well, that's not going to work, and might as well just start something else in 3 months. Now, of course, it's not the fault of the patient. It's the fault of poor non-pharmacological lifestyle behavioral management as far as your clinic is concerned, right? The suggestion is you should fix that. Anyway, if the patient is not yet 130, but getting to 130 systolic, do healthy lifestyle. Okay, so promote non-pharmacologic or do non-pharmacologic therapy and regularly check on the blood pressure, maybe 2 to 4 times a year. Now, if the patient has significant risk factors and is over 130 systolic or over 80 diastolic, like the risk is over 10%, or you're using a new tool and you came up with a risk that's higher than 10%, then do the non-pharmacologic lifestyle stuff, but also start the medication. So that's the general idea right now. Now, if the patient comes in with something above 140 systolic or 90 diastolic, go for the drugs as well as the non-pharmacologic lifestyle management, and keep at it until you reach the goal. And reassess again. To make things simple, it's again every 3 to 6 months. Now, obviously, if the blood pressure is significantly high and it's causing symptoms, like, the patient's having really bad discomfort at 150 systolic or 160 systolic, you don't wait 3 months to control the blood pressure, but just allow him to suffer the neck pains or headache or whatnot for 3 months, right? Now, at normal BP, you'll notice that most recommendations will say you still should promote healthy lifestyle. The other thing that's different is the medication. Before, several decades ago, beta blockers were very popular. Nowadays, it's the 3 big popular drug classes: the diuretics, which are the thiazide or thiazide-like drugs; the angiotensin drugs, which includes the angiotensin converting enzyme inhibitors, or what we call ACE inhibitors; and the angiotensin receptor blockers, or what we call the ARBs. And the third class would be the long-acting dihydropyridine calcium channel blocker drugs, which includes the very cheap, affordable, and popular amlodipine, felodipine, and the like. Now, what do you use? Well, the general idea is if you live in a place with enough resources, then you do the test to figure out whether the patient has significant risk, has a comorbidity, has a kidney problem or heart problem, so that you can choose well. Now, if you don't have that much resources and these tests won't get done, or it will take several weeks of saving money to get things done, the suggestion is you should treat the blood pressure instead of waiting for the tests to get done. If you're worried about potassium levels or kidney problems or any other thing that can be worsened by your choice of drugs, then you can choose the least problematic among the 3. That would be your long-acting dihydropyridine calcium channel blockers. And then, after you get all the tests done, you can always modify the medication. Now, something newer than the idea of using one of these 3 drug classes would be the idea of using combination pills, meaning instead of monotherapy, you'll be using 2 drugs in 1 pill. And the idea is it works better in controlling your blood pressure, and so it also decreases significantly your cardiovascular risk. So that's the not so new but sort of new thing right now. Now, of course, when you look at all these guidelines, especially the ones which are not, even the ones written in developed countries, because, just because it's a developed country doesn't mean all the communities inside that country have a lot of resources. But, anyway, if you look at the guidelines, especially those that are meant not only for highly resourced countries, but also for moderately or low resource countries, they would say something like, we suggest that you use a combination drug therapy. But then they'll also say that they recognize that it would require a lot of resources to procure the drug and then supply the drug to your different health centers, lower the drug cost, make it affordable for the general population, especially the low-resource population and such, because the combination drug is obviously more expensive than your single drugs. And so you also see the difference between the recommendation. For example, we recommend you use this because this is very beneficial. It will decrease your risk for so-and-so, compared to, well, we recommend this, but we know that it's very expensive and you'll need a lot of resources for this. Therefore, we highly suggest that your country or your government or your medical community try to look for ways so that you can get this done. So those are 2 different things, right? So that also means that, the suggestion is there, but you're on the ground. And if the suggestion is not feasible, then do what's feasible and work towards being able to do what the suggestion says, right? First, do what's doable and feasible, then try to improve the situation so that you can do something better according to what's on the guideline. Now, the next tricky part, which is also related to resources, would be the tests you order. Well, the general idea is you want to order the test because you want to know if there's a cause to the hypertension. If it's secondary hypertension, you want to figure out what the kidney looks like. You also want to figure out whether there's comorbidities like diabetes or heart problem. You want to know whether there's already complications or organ damage like kidney problems or heart problems. Why? Because this will help you tailor fit your management and your drug selection according to what the patient has. If he has secondary hypertension or a kidney problem or a diabetes, then you'll be able to choose better, right? Now, the problem is you might not be able to do the test right away if you're in a low resource country or community, even if the tests are very simple. For example, the basic suggestion would be electrolytes, creatinine, cholesterol, or the so-called lipid panel, fasting blood sugar or fasting blood glucose. Now, if you have more resources or money, maybe you can go for the more expensive hemoglobin A1C, urine dipstick, and ECG or electrocardiogram. Now, the suggestion is, it's nice to do these things because you can come up with a better regimen, a better guided regimen. But if you cannot, don't postpone your treatment. Just treat it right away. If you're concerned that there's a potassium problem or a kidney problem or your drug selection might worsen the situation, then go for the least likely to cause problems. And usually that means your long-acting dihydropyridine calcium channel blockers, like your amlodipine. And then after you're able to do the testing, then you can always modify and improve your regimen. Now, of course, if you're not too concerned about any problems that might be worsened by your use of diuretic or an ACE inhibitor or an ARB, then go ahead and use a combination pill. Maybe use the less problematic long-acting dihydropyridine calcium channel blocker together with one of those ACE inhibitors or ARBs, or maybe even a diuretic.